Today I'm having a discussion with my friend Ralph Stefan van Bardeleben from Mainz, and we are going to address the issue of percutaneous transcatheter intervention. So Ralph, the first question we may put forward is, do you think that the cardiology community has a sufficient awareness of the disease of mitral regurgitation?
If you look into the German heart report 2015-2016, there is an analysis, statistical analysis, that the number of patients over 80 years of age with severe mitral regurgitation has increased from 2000 to 2014 by 94%. So I think after the awareness now for the very good indication for TAVI, there is a beginning awareness for mitral valve disease and mitral valve regurgitation in the cardiology community, I think.
I think it's a very good point. So hopefully the patient will get involved and our colleague will also feel that something should be done. So let's say there are plenty of patients with this disease. It's not good to have this disease, so we should treat them. We do agree that surgery is the gold standard, but not always. And we should consider transcatheter treatment. So you have a very large experience with all sorts of transcatheter mitral treatment. So what is your advice to colleagues who are willing to start a transcatheter mitral valve program?
I think the first situation is structural quality of the cardiology department. So it all starts with a very good imaging department that is able to screen mitral valve regurgitation, that is able to differentiate the two major etiologies of mitral regurgitation, which is degenerative disease or primary MR, and secondary MR, which is a disease of ventricle or atrium. And I think this is the first step. Imaging is also required throughout all procedures, so it's much more important than the field of aortic valve pathologies. It is important during screening, during the decision which device to use, and also during the guidance in the intervention in the cath lab. You will need a cath lab with an adequate hygiene level or a hybrid OR to perform your procedures, and a heart team is advisable due to the German standards in order to decide on adequate treatment. So a heart surgeon and a cardiologist and an anesthesiologist should always be involved.
So you mean center experience in valvular heart disease, the so-called center of excellence? Huh?
Yes.
That's a very good point. So let's say patients are aware, cardiologists are aware, you have a nice setup. Now, what about the current results of the percutaneous valve intervention we can propose?
We have to say that the procedure and the technique has come of age. So comparing this to the year 2009, when we just had procedures in the hundreds or beginning of 1,000 implantations, we now have an experience in the most advanced setting, which is the edge-to-edge repair technique percutaneously, of more than 34,000 implants worldwide. So there is a gaining and huge experience in this field. If we look back to the annuloplasty and to the chordal replacement percutaneously, these techniques have an experience worldwide of about 500 implantations each. So this is the current standard. The success rate of the implant has risen from the early days from 77% up to 97 to 99% implant rate and success rate to achieve good instantaneous results, which in part are stable over 1 to 5 years, as we have seen in the EVEREST trial, as we have seen now in the new publication of the TAVI registry, which is the German largest worldwide registry on mitral valve repair percutaneously, with more than 1,300 patients.
And we have some long-term results now.
We have long-term results now, so we're expecting the 6-year results of the EVEREST trial. We have the whole intervention now has a history of about 13 years, and we have patients surviving these 10 to 13 years already with these devices.
And very interestingly, you know, in Germany you have a very easy, or let's say, open access to many of these techniques. And can you just repeat and tell to the colleague what is grossly the ratio between surgical mitral intervention and transcatheter mitral interventions?
Like in TAVI, where we have a relation of about 16,500 TAVI procedures in Germany, we now have about 5,000 mitral clip procedures and about 200 annuloplasty procedures in Germany. This is in comparison to about 4,000 surgical mitral valve repair procedures and 2,000 replacements in the year 2015.
So the future is there. But lucky we are. There are several strategies, two main strategies. Either we go for transcatheter mitral repair or replacement. Can you tell us what is your view for the future? Which one will be the winner? One, the other one, both? Or?
I think there are three major points we have to consider. The first one is patient safety. And I think the current repair techniques have proven excellent patient safety profiles. The second point is durability. We know that repair procedures have a durability of 6 to 9 years. This has to be proven by the mitral valve replacement programs. And also the mortality is excellent in the repair program. This is beginning to improve also, like in TAVI in the years 2003 to 2009, this is also going to improve in the mitral program. So depending on the time frame, I would say there will be an increasing number of mitral valve replacements in native valves in the next 5 years. But I think the number of these replacements will not exceed 20 to 30% in the next 5 years. If we have improvement second generation valves, we will see and have transeptal approaches which are better in safety than transapical approaches from the heart apex. I envision that between the year 5 and 10, we will see approximately 50 to 60% mitral valve replacement compared to repair in the future. But this is a rough estimate. We're bad in looking into the future.
Well, you're not that bad. At least you are excellent looking at the present and the past, because summarizing such a difficult and complex issue within a few minutes is, a real challenge. So I think the colleague did understand that it's a complex disease. It will take more time to develop than the aortic field, the aortic TAVI, but in the near future, our patient will be no doubt the winners, as we discussed a minute ago, the winners, because they'll have available several options. So thank you, Ralph, for this great overview. Thank you.
Thank you very much.